This is the second pilot module in Nebraska's training for new staff members working in lead poisoning prevention. You will need internet access to view videos included in this module. You will also have an opportunity to review other information by clicking on the links provided in the slide. Slides will automatically advance with each voiceover. If you wish to move more quickly, please right-click to advance to the next slide. Early in the module, you will see a link to a pretest. At the end, you will see a link to a post-test and evaluation. Please complete both before you exit this module. We will cover 4 major topics in this module. Now take a minute to complete the pretest. When finished, return to the module. Our goal here is to help you understand what the measure means, the rationale behind the CDC reference level, and how Nebraska has begun to implement its lead poisoning prevention guidelines. At the end of the module, we will return to the discussion of primary prevention. Here, we hope to give you a perspective on what can be the next step in your communities for lead poisoning prevention. Regardless of how the sample was obtained, all laboratories in the U.S. report blood lead levels in terms of micrograms per deciliter. As the definition shows, laboratory tests can detect a very small amount of lead in the blood. This also means that a very small amount of lead in the blood has been shown to have significant health effects. The current CDC reference level is 5 micrograms per deciliter. If you prefer to see the measure explained in a different way, click on the Mission Unleaded logo, where you can see a video that the Centers for Disease Control and Prevention has prepared. Start at minute 1.52. The explanation lasts approximately 1.5 minutes. As we saw in the last module, the average blood lead levels for the nation have declined. In 2012, CDC stopped using the term level of concern to describe the point at which public health should take action to address an elevated blood lead level. This reflects our understanding that there is no safe level of lead in the blood. As we shall see in the next module, even a very small amount of lead in the blood is associated with poor health outcomes. CDC's National Blood Lead Reference Level is intended to identify children whose blood lead levels are much higher than most children's. The new level is based on data for a sample of U.S. children aged 1 through 5 years tested for lead in their blood as part of the National Health and Nutrition Examination Survey, or NHANES. NHANES is a population-based survey to assess the health and nutritional status of adults and children in the United States. It is used to determine the prevalence of major diseases and the risk factors for those diseases. The reference level represents the value of the highest 2.5% of children who were tested. The current blood lead reference level is based on NHANES data from 2007 through 2010. Every few years, CDC will review the most recent 2 sets of NHANES data to find the 97.5th percentile. That means that the reference value may change in the future. If you would like to see the reference value explained in a different way, click on the Mission Unleaded video and advance to minute 3.33. This explanation will take about 4 minutes. We have also provided the link so you can view the video at a later time. Return to the module when you have finished viewing the video. Take a minute to reflect on what CDC's reference value means. The correct answer is the last one. Just a reminder that there is no scientific evidence for a safe level of lead in the blood. The reference value is based on national data and does not reflect the average blood lead level for each state. The reference value will change over time. In the earlier module, we reviewed some of the federal actions to address lead exposure. The state of Nebraska has also adopted legislation and administrative regulations to define the scope of its authority to take action. Nebraska's Childhood Lead Poisoning Prevention Act created the state's Childhood Lead Poisoning Prevention Program, or the state CLIP. The legislation required the Department of Health and Human Services to define what it meant by an elevated blood lead level, require laboratories to send all testing results to the state, develop a plan for testing children at risk, and develop educational materials for healthcare providers and the public. It also gave the CLIP the authority to contact healthcare providers and local public health departments to provide technical assistance when it received a notice of an EBLL. The Residential Lead-Based Paint Professions Practice Act sets the standards for what is considered a lead hazard, as well as the training and licensing requirements for workers who disturb lead-based paint and the penalties for firms that undertake lead remediation with unlicensed workers. Authority to implement these laws are embodied in the Nebraska Administrative Code in Title 178, Environmental Health, Chapter 23, Lead-Based Paint Activities. To learn more about these laws, click on the name of the legislation. Through the authority provided under these laws and regulations, Nebraska has taken some important steps to incorporate the CDC reference value into its policies and procedures. Take a minute to look here. Note once again that any initial EBLL should be confirmed with a venous test. Nebraska's guidance requires that action must be taken to prevent confirmed blood lead levels from increasing. It also provides that exposure must be eliminated in order for management to be considered successful. Basic management activities include identifying and eliminating exposures, assuring that siblings are tested, educating the family, improving the child's nutrition, and regular monitoring of blood lead levels. The specifics of testing requirements will be reviewed in a later module. The activities addressed in this slide are considered secondary prevention. Local health departments perform these basic activities directly or with support of the state CLIP. They include timely data entry, contacting the parent, family education, contacting healthcare providers, collecting an environmental history with possible referral for an environmental investigation, and finally, case closure. While the healthcare provider, or HCP, provides direct medical management of the child, Nebraska's policy specifies how local public health supports these actions. This guidance also provides direction on how to follow through on disease investigation and what is required for environmental follow-up with a child who has an EBLL of 5 or greater. Take a minute to review some of these actions. Many local health departments are beginning to do more than this through their case management activities. Case management requires more effort to get to the root of the problems and family needs. The state does not do case management. This is a local action. But the state recognizes local programs may be at the very beginning of their case management efforts or vary in their resources to do so. With time, the state wants to see local public health departments expand those efforts. For now, recognize that case management assures each child gets the services he or she needs. This may involve a local public health department, a provider at a healthcare facility, or a Medicaid case manager. It is a team approach. Later modules will discuss strategies to strengthen local case management activities. Take a minute to think about Nebraska's regulations for EBLL management. Which of these statements are true? The first statement is true, but the other two statements are false. Under Nebraska's guidelines, healthcare providers have primary responsibility for medical management, while local public health has primary responsibility for disease investigation. The state CLIP has responsibility for environmental investigations. The state does not provide case management services. We know that local public health has a variety of responsibilities under Nebraska's policies, but keep in mind that secondary prevention will not achieve the ultimate outcome of preventing all children in the community from exposure to lead. Significant progress has been made in reducing U.S. blood lead levels over the past 3 decades by limiting lead's use in consumer and other products, but the hardest part remains. When a child presents with any measurable blood lead level, the exposure has already occurred. We know that many children who are exposed never receive tests. Others are tested at a later age, when damage to the developing brain and nervous system has already occurred. Moreover, a secondary prevention approach only addresses exposures for the family with a child who has an EBLL. Even when everything works, we are only fixing one house at a time. And finally, there is no miracle drug to fix an elevated blood lead level. Medical management through chelation therapy, a treatment which draws lead out of the blood and soft tissues, is an option for only a fraction of children at very high blood lead levels. The benefits are modest, and the treatment comes with health risks. So to put it bluntly, screening and case management rely on children as lead detectors to find hazards in their homes. From a societal perspective, primary prevention has a bigger bang for the buck than many other strategies to address lead exposures. Recall that primary prevention is the removal of lead hazards from the environment before a child is exposed. It ensures that children do not experience harmful long-term effects. In 2017, a team of experts looked at the impact of 10 federal policies to reduce lead exposure. The goal was to identify those policies whose cost to implement were less than the expected lifelong benefits for a cohort of U.S. children born in 2018. 3 policies all had fewer costs to administer than long-term benefits. These are increased enforcement of the renovation, repair, and painting rule, removing lead-based paint hazards from low-income housing, especially that built before 1960, and reducing lead in drinking water in homes built before 1986. So what does this mean for you? As part of building a successful local lead poisoning prevention program, public health needs to start strategic planning with a variety of new partners. Your program may not have the resources to undertake primary prevention now, but your senior staff may need to start building the relationships that will help your program get there. You can help. First, find out who is doing the work in your community that could address lead hazards. Could you help train volunteer rehab programs, including Habitat for Humanity, Rebuilding Together, or other faith-based programs? Could your program work with public housing agencies as they implement building upgrades? Could you work with other organizations that build or renovate housing? And do you know how your housing code enforcement agencies take action when they find chipping or peeling paint in rental homes? Next, think about how your program could provide tools to other programs. What about sharing your educational materials with other home visiting programs, or setting up joint referrals for services? How can your program improve its collaboration with local educational institutions? Think broadly about this. Could you use interns to do some of the work? Work with researchers? Encourage local law schools to work on legal issues related to access to high-quality housing? Could your program convene a task force on lead poisoning prevention for the entire community? And do you share your data on lead poisoning broadly with other programs? Think also about how your program could do more to educate and build support for reducing exposures through outreach to community groups and key stakeholders. Keeping community awareness high about the dangers of lead exposure helps to build a climate for action. When thinking about partners in primary prevention, don't just think about your program's usual partners. We have a lot of opportunities to build collaborations. So let's think about how to handle this situation. Which would be good arguments for more primary prevention funding? Efficiency, building community awareness, the benefits outweigh the costs, or there's no medical fix? The answer is all of them. As your programs begin to think about primary prevention, here are 2 CDC documents you might want to review. Building Blocks describes strategies that communities across the country have successfully used to build awareness and support, expand local capacity for lead hazard control, improve collaborations, fund programs, and other activities. Each example describes the expected benefits, key actors, elements for success, and potential obstacles or barriers from the strategy. Preventing lead exposure identifies 8 elements that should be part of strategic plans for primary prevention. Click on the cover page images to learn more. Take a minute to review these key messages. We hope that this module has improved your understanding of definitions and policy at the national and state level for lead poisoning prevention. Please click on the link to complete the post-test and evaluation. Thank you.